This conference will now be recorded.
All right, so we're going to talk about chest injuries. Hopefully the slides are changing with me speaking with this. The internet here is pretty slow at the action base. So we're going to cover the National EMS Education Standard Competencies, which applies fundamental knowledge to provide basic emergency care and transportation based on the assessment findings for the acutely injured patient. Except this time we're going to focus more on the chest trauma and recognition of management of blunt versus penetrating mechanisms, open chest wounds, and impaled objects. We're going to go through the pathophysiology and assessment and management of blunt versus penetrating mechanisms in hemothorax. And the pneumothorax, so it'll be open, simple, or tension. We're also going to cover cardiac tamponade, rib fractures, Commotio Cordis, and flail chest. So each year in the United States, chest trauma cases cause more than 700,000 emergency department visits, along with 18,000 deaths per year. Chest injuries can also involve the heart, lungs, and great blood vessels as well, including like the aorta and things like that. Maybe a result of blunt trauma, penetrating trauma, or both. So we need to look and immediately treat injuries that interfere with normal breathing function. So if we have a tension pneumothorax, a hemothorax, things need to be treated quickly and aggressively with this. And internal bleeding can also compress the lungs as well as the heart. And air may also collect in the chest, preventing lung expansion. So that'd be more of your pneumothoraxes. So a little bit about A&P, kind of like a review. Remember that the difference between ventilation and oxygenation. Ventilation is the body's ability to move air in and out of the chest and lung tissue, but oxygenation is the process of delivering oxygen and blood by diffusion, so air moving from greater concentration to lesser concentration from the alveoli following inhalation into the lungs. So we have to be able to have air moving in to oxygenate the cells and to get into the bloodstream via transport through the hemoglobin and red blood cells into the capillary beds where our gas exchange happens. We start getting perfusion. If we have an inadequate state of tissue perfusion, that becomes shock. So the chest or thoracic cage extends from the lower end of the neck to the diaphragm. So that's going to be our thoracic cage. So the bottom part of the neck, right, which extends to the lower end, excuse me, to the diaphragm itself. And that's going to be our thoracic cavity. So everything underneath the chest wall. So the thoracic skin, muscle, and bones, as well as similarities to the other regions, also unique features allow for ventilation, such as striated muscles. So if you look at the screen, and I'm not sure what you guys can see now, because I think things are moving a little slow on your end, but I'm not exactly sure. So we have our heart obviously located here. With that, we have our pulmonary arteries. We have two lungs. We have the pleural lining of the lung, which is that darker purple line that runs along the lung edges. We have our superior vena cava, the aorta that runs right down through here, and the subclavian arteries, which run through here, underneath the clavicle. Think subclavian, underneath the clavicle area. In our lungs, we have different lobes within the lung. So on the right side, we have three different lobes here, one up top, middle, and bottom. On the left, we have two lobes, 1 and 2. And then our heart takes up one spot where a lobe would actually be as far as the lung goes. So as you can see, the diaphragm runs from just below the clavicles here, bottom part of the neck, and extends down to the lower part of the rib cage down here. And this is the thoracic region, thoracic cavity. So the neuromuscular bundle lies closely, along the lowest margin of each rib. and the pleura, covers each lung in the thoracic cavity, so the pleura around it. So a small amount of pleural fluid between the parietal and visceral pleura allows the lungs to move freely against the inner chest wall during respiration. So think about it allows us to move so in and out. Take a deep breath in, lungs fill up with air. Take a deep breath out. The lungs start to contract, pushing the air back out again. There are some vital organs, such as the heart, that are protected by the ribs. As you can see, the rib cage is here. We have ribs, and we have our costal cartilages, which are run to the sternum. In between each one of these ribs is called an intercostal space. So I'm sure you remember me saying that before. Intercostal spaces are where we actually put in our 12 lead EKG placements when we're talking about getting a 12 lead for cardiac management. So you have to be able to count the intercostal spaces between 1, 2, 3, 4, 5, 6, 7, 8. Work our way down through the ribs and in between. On the bottom part of each one of these ribs that are in here located are major arteries and veins, which is why when paramedics do chest decompression, they always ride the top of the rib where there's nothing there. So vital organs such as the heart are protected by the rib cage, protecting the thoracic cavity. These are connected into the back, into the vertebrae, and connected to the front, to the sternum. So it starts from the vertebrae out back, and they wrap around, making a cage into our costal cartilages that connect to the sternum itself, protecting a very strong cage around our vital organs. The mediastinum contains the heart, the great vessels, the esophagus, and the trachea. So think about the upper part of the chest. A thoracic aortic dissection can develop in this area of the chest, where we have aorta actually dissecting, causing a significant bleed. So the diaphragm and the muscle that separates the thoracic cavity from the abdominal cavity. That's the muscle between the two. So mechanisms of ventilation. So the intercostal muscles between the ribs contract during inhalation. So we take a deep breath, the diaphragm contracts at the same time, filling up with air. The intercostal muscles in the diaphragm then relax during exhalation, so we're in a relaxing state. Take a deep breath out. With that happening, our these are starting to relax, causing the air to squeeze to push the air back out again. Remember that our lung system runs on a negative pressure system, so the body should not have to work to breathe in a resting state. It's when we start having to work to breathe is when we start needing to take some more interventions. So as you can see in this picture over here in the more of the grayed out area, you have an inflated lung. This is during inhalation. So the diaphragm starts to expand. Here's your liver down here. Your liver intestines run down. So as your body is, as your diaphragm is expanding, causing muscle use to do so, it starts to expand as air comes in. As you take a deep breath out in the relaxation phase, you can notice how the liver is compressed a little bit here. Everything pushes back out to a normal phase. It's a little bit bigger on this side here. The diaphragm relaxes, muscles start contracting, going back in. This is causing the lungs to deflate and push the air back out again. So patients with a spinal injury below C5 can still breathe from the diaphragm. We talked about C3, 4, and 5 keep the body alive. So as you can see, patients with a spinal cord injury above C3 may lose the ability to breathe because you have sort of paralysis of the muscles as from the shoulders down. So C6 is located here. We can have complete paralysis from here down. Breathing only by the diaphragm only. We saw the paralysis of the rest of the muscles below the shoulders, and then loss of sensation from the shoulders down, which is why it's so important when we deal with spinal injuries that we have cervical spinal mobilization. So minute ventilation or minute volume is the amount of air moved through the lungs in 1 minute. So what we do is you take the normal tidal volume of the patient, which is usually between 4 to 6 mLs per kilo, and times that by the respiratory rate, and that will give us our total minute volume. Patients with a decreased tidal volume will have an increased respiratory rate. So if we have low volume, we have higher rates. So there's two types of injuries to the chest. There's open and then there's closed. Obviously open, a closed chest injury, the skin is not broken, generally caused by blunt trauma, as you can see here. This looks more like a seatbelt mark that comes across the chest. This would be more of a blunt trauma or a closed type injury. This can cause fractured ribs, potential for a clavicle fracture up here, rib fractures down here, also potential for a pneumothorax depending on how hard this is pushed against the chest. These can cause significant cardiac and pulmonary contusions or a cardiac tamponade, causing extreme swelling and fluid around the lung, around the heart, and also around the lung for a pulmonary contusion as well, and swelling and blood as well. If the heart is damaged, it may not be able to refill with blood, or blood may not be pumped with enough force out to the heart. Lung tissue then becomes tissue bruising, can result in exponential loss of surface area, therefore you can't breathe as effectively. And rib fractures can also cause further damage, as the fractured ribs can become very sharp and can puncture the lung as well. As you can see here in this picture, we have an open chest injury where the object penetrates the chest wall. You can see the blood coming out through here in penetration. A knife, bullet, or piece of metal or broken end of the fractured rib can cause this. If it is in place, do not attempt to move or remove the object. We just need to put an occlusive dressing over this and treat that. Over there, we stop losing air. Patients in this aspect also may require a decompression. So blunt trauma to the chest may cause rib, sternum, and chest wall fractures. Bruising of the lungs and heart, or pulmonary contusions we were talking about. Damage to the aorta as well. Remember that the aorta is the same size of a quarter in diameter, which is a lot of blood flow. Vital organs may be torn from their attachments in the chest wall cavity. So remember we talked about motor vehicle accidents before, where there's three different impacts. There's the impact of the vehicle hitting the tree, you hitting the steering wheel inside, and then your internal organs hitting you, hitting the muscular the chest cavity and whatnot. So signs and symptoms of chest injuries would be pain at the site of injury, localized pain aggravated or increased with breathing, bruising to the chest wall, crepitus on palpation of the chest, penetrating injury to the chest, and dyspnea, so shortness of breath. So remember, when you're doing our assessment, we have to palpate each rib as we go down through and get a good chest rise and fall, make sure we're getting good expansion and then relaxation. If they're unequal, then that could be potential for a pneumothorax or a collapsed lung. But as we're palpating, also, if you have flail segment, which is 2 or more broken ribs in one spot, in conjunction, in consecutive order, you may feel an indentation as you're taking a deep breath in, and then back out again. You may see some hemoptysis, so vomiting of blood. As well. You could have rapid or weak pulse, low blood pressures, and cyanosis around the lips and fingernails. Failure of one or both sides of the chest to expand normally with inspiration. So these are some signs and symptoms of the chest injuries. And also make sure you get a very good set of lung sounds, as that could mean the difference between the collapsed lung or not, and be able to hear either absent or diminished sounds on one side. Chest injury pattern patients also have rapid and shallow respirations. It hurts to take a deep breath, which means patients may not be moving enough air. And then so auscultate multiple locations to assess for adequate breath sounds. If they're breathing shallow, they're not getting a good oxygenation either. Therefore, we're going to not be able to perfuse at the cellular level as appropriately. And it could be due to extreme pain if they're breathing shallow. And if they're breathing shallow and breathing rapid, eventually they'll be retaining too much carbon dioxide, and they'll cause themselves to pass out. So when it comes to scene safety, ensure the scene is safe for you and your partner. Obviously, make sure if there is a crime scene, do not disturb any evidence. Request law enforcement for scenes involving violence, and remember gloves and eye protection. Looking at the mechanism, again, just going back to the previous chapter we just covered, you've got to look for injury patterns in the vehicles. So look at your windshield, your steering wheel, underneath the dash, things like that, where they seatbelted, not seatbelted, or seatbelt marks. What did they come in contact with? Is there any intrusion into their vehicle versus just on the outside? So take a look at all this stuff when looking at your mechanism of injury. We're going to determine the number of patients in the vehicle. Remember that if there is a fatality in the vehicle on one patient, you need to consider the other patient critical. As the forces were strong enough to kill the other patient, doesn't mean that something isn't seriously wrong with the one that's currently still alive. Consider spinal mobilization. We're going to form our general impression by addressing life threats and also treating any life-threatening hemorrhage. We're going to note the patient's level of consciousness, utilizing our AVPU scale: alert, verbal, painful, unresponsive. We're going to perform a rapid physical exam, looking for obvious injuries, appearance of blood, difficulty in irregular breathing, and cyanosis, looking for the blue colors of the skin or around the lips. Within our rapid assessment, takes no more than 90 seconds. We're going to perform the rapid scan, looking for chest rise and fall. If you notice anything only one side or not, we're going to look for accessory muscle use, extended or engorged jugular veins, and the ABC is also assess overall appearance. Why would you think to look for extended jugular veins or jugular vein distension? What do you guys think? Hopefully you guys can reply back.
Collapsed lung.
Not so much a collapsed lung. You look for the tracheal deviation. Think more about jugular veins coming in right ventricle, right atria functioning, pumping into the right ventricle that goes into the lungs, into the left atria to left ventricle, right? So if we have a heart that has fluid around it, would that cause jugular vein distension?
Yes.
Yes, absolutely. So what we're looking for is something called Beck's Triad. So Beck's, B-E-C-K-S, Triad are three things that we look for in the assessment to find out the patient has a cardiac contusion or a pericardial tamponade. All right. The three things we look for: one is JVD, jugular vein distension. The second thing we look for is muffled heart sounds. All right. So you take a stethoscope, place it over the heart, take a listen. If it sounds muffled, that's the second thing. The third one we're going to look for is narrowing pulse pressures. So if you take a blood pressure on somebody and their blood pressures are systolic, diastolic are very close to each other, let's say 90/86, something that close. With that being said, those are the three things we look for Beck's Triad. So JVD, muffled heart tones or muffled heart sounds, and then narrowing pulse pressures, so close systolic, diastolic pressure. If you have those three things, they have a pericardial tamponade. They need to have a pericardial centesis done, which is done in the ERs, where they stick a long needle into the heart and pull fluid from away from the heart, from that contusion, from that trauma that they had with that. We look for airway and breathing as well, and ensure the patient has a clear and patent airway. We're going to consider early cervical spine stabilization if appropriate. Again, are the jugular veins distended? We need to look for that. Is breathing present and adequate? If it's not, we need to fix it. We're going to expect for decap BTLS, the deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, swelling. Decap BTLS. We're going to look for equal expansion of the chest wall. By doing so, We're going to go underneath the breasts of a female, the pectorals of a male, wrap your hands around the chest and take a deep breath in and out. And we're looking for paradoxical movement. So is one side going up versus the other side staying down and vice versa. Apply occlusive dressing to all penetrating injuries. Remember, we want to limit the amount of air going in. So what we do is we take an occlusive dressing, place it over the hole in the chest, leaving one side open. By doing so, when the patient breathes out, they can still exhale. It'll come through like a flap. But as they're breathing in, it sucks that dressing right to the chest wall so the lungs can expand appropriately. So we can work with that negative pressure system. We're going to apply the occlusive dressing, and then we're going to support ventilations as needed. And that may be as simple as putting on an on rebreather or going to a BVM to assist. We're going to reassess the effectiveness of ventilatory support. We have to continue reassessing that to make sure we're getting good compliance. Good compliance means that the breaths go in effectively and not causing gastric distension. Be on the alert for decreasing oxygen saturations, as if a patient has a collapsed lung, that can decrease pretty quickly. And that also be alert for the impending tension pneumothorax. We're going to check rate, rhythm, and quality of the pulse. We're going to look at skin color and temperature and address any life-threatening bleeding immediately using direct pressure and a bulky dressing. Remember that if you have a fast pulse rate, fast respiratory rate, and decreased blood pressure, the patient's in shock. Okay, they're in a compensated shock. Along with the skin color and temperature, you're going to find the patient to be pale, clammy, and diaphoretic. We need to make a transport decision based on the priorities of those with a problem with ABCs. Pay close attention to subtle clues like appearance of skin. We talked about the pale, diaphoretic, cool, and clammy. Level of consciousness utilizing your AVPU scale and a sense of impending doom in the patient when they tell you, I'm going to die. I feel like I'm going to die. That's impending doom. They probably are going to die. So we need to start treating patients quickly to keep them from getting into that point and keep them out of that irreversible or decompensated shock. This is the deadly dozen chest injuries. So we talked about airway obstruction, bronchial disruption, diaphragmatic tear, esophageal injuries, open pneumothorax, tension pneumothorax, massive hemothorax. So that's air and blood in the lung. Flail chest, cardiac tamponade, thoracic aortic dissection, or leaking from a traumatic aneurysm of the portion of the aorta that lies within the chest. A myocardial contusion, or bruising of the heart, or a pulmonary contusion, or bruising in the lungs. So we're going to investigate the chief complaint, further investigate the MOI, look into what's going on there, identify signs and symptoms and pertinent negatives. Sample history utilizing signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading to illness or injury. Then a basic evaluation should be completed, and we need to focus on the mechanism of injury that's there. How much blunt force trauma was done, or how much penetrating trauma was done, and where it was done to. We're going to look at physical examinations for isolated injuries. Do a focused exam on the isolated injury that's there. Look at the patient's complaint, the body region affected, location and extent of the injury, interior or posterior aspects of the chest wall, any kind of changes in respirations. We got to keep an eye on that as well. For significant trauma affecting multiple systems, start with a rapid physical examination. Remember, that's your head to toe, no more than 90 seconds. Using DCAP BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, laceration, and swelling to determine the nature and extent of the injuries that are there. So palpate, touch, look, listen, feel. Vital signs, obviously, we're going to assess the pulse, respirations, blood pressure, skin conditions, and pupils. Also check pulse oximetry as well, and lung sounds. Reevaluate every 5 minutes or less. And same thing, when you're doing your vital signs, respirations, check lung sounds because things can change. Pulse and respiratory rates may decrease in later stages of the chest injury. All right, so as we get more swelling or more damage in the chest starts getting worse and worse, we may have respiratory rates and pulse rates changing. We want to be able to pick up on these signs and symptoms earlier than later. We're going to repeat the primary assessment. We're going to reassess the chief complaint. We're going to reevaluate ABCs, airway, breathing, pulse, perfusion, and bleeding. There we go. Oh, a little too far there. Let's see. Lost my mouse for a minute. We're going to reassess vital signs and observe trends. Provide appropriate spinal stabilization when indicated. Open airway, maintain an open airway. Again, they may vomit. They could start getting secretions in the airway as well, so suction them out. Control any significant visible bleeding, and place an occlusive dressing over penetrating wall trauma to the chest wall. For patients with signs of hypoperfusion, provide aggressive treatment for shock and rapid transport. So treatment for shock obviously is high flow oxygen, getting ALS on board and keeping them very warm. Do not delay transport to complete non-life saving treatments. And do not delay transport to complete those treatments as well. Communicate all relevant information to the staff at the receiving hospital. Give them a heads up coming with a trauma alert. Because the last thing you want is be 5 minutes out giving an update and they don't have the appropriate personnel in the ER waiting for you. So if you're on scene coming with a trauma alert, give them 25, 30-minute ETA. At least that way don't give them the full report. Let them know what you're coming in with quickly so they know. That way then you can, when you're 10 minutes out, give an update on the report you initially gave so they know what to plan for. Pneumothorax is commonly called a collapsed lung, which is an accumulation of air in the pleural space. So blood passing through the collapsed portion of the lung is not oxygenated at that point. So you may hear diminished, absent, or abnormal breath sounds on one side. As you can see in this photo here. All right, so this is the normal lung over here. Let's say the heart's sitting right here. This is the right lung. So we have the visceral pleura on the outside. This is the collapsed lung. This is airspace inside the parietal pleura is on the outside, but this is all airspace inside of here. This is not normal. This is supposed to collapse with it. So when you have a hole in the lung, the air is coming out, filling this space, which is why they do a needle decompression through into the lung, allowing the air in the lung to reinflate by doing so. Remember, because the lung runs on a negative pressure system. So open chest wound pneumothorax, often called an open pneumothorax or a sucking chest wound. Wounds must be rapidly sealed with an occlusive dressing, and a flutter valve is a one-way valve. Carefully monitor the patient for extension of the pneumothorax, retention pneumothorax. What they're talking about with flutter valves or one-way valves is applying that dressing on three sides, leaving one side open so it kind of flutters only on the way out. That's one thing that we can use. As well. So Maine used to carry, and I think they still do on the ambulances, saran wrap, and that used to be really good for that. So you tape it off and then leave one side open. Air could come out, but then it couldn't re-enter. So as you can see, the pneumothorax here. Air comes in, air goes out. We want to prevent air coming in by putting an occlusive dressing over the top of that, so air can still come out, but not come back in again. A simple pneumothorax does not result in major changes in the patient's cardiac physiology. Commonly due to blunt trauma that results in fractured ribs and can often worsen, deteriorate into a tension pneumothorax or develop complications. A simple pneumothorax may not do anything at all. They'll be treated at the hospital. We get into a tension pneumothorax, that's the result of ongoing air accumulation in the pleural space, which increase pressure in the chest, causing complete collapse of the unaffected lung. Mediastinum is then pushed into opposite pleural cavity. Common causes of a blunt force injury were fractured ribs or lungs or bronchus. So these are patients that need chest tubes placed and chest tubes done immediately. So patients that have tension pneumothorax, these are the ones that need to be flown to a trauma center. All right, so you can see the wound site here. And air would come in. And what's happening is this becomes compressed and it's shifting everything over. and then it starts compressing the affected lung. So we got to reinflate this. And by doing so, they're going to come in with a chest tube between the 5th and 6th intercostal space over here with a tube in place to help drain the fluid or the blood out of the area. So a hemothorax is blood that collects in the pleural space from bleeding around the rib cage from a lung or great vessel. We really don't know about the hemothorax until we put a decompression needle in place and see blood come out versus air. But as you can see here, now we're bleeding into the lungs. The lungs start to fill up with blood. That's the hemothorax. The pneumothorax is airspace inside with blood on the very bottom. So signs and symptoms: shock without any obvious external bleeding or apparent reason for shock. Decreased breath sounds on the affected side. For pre-hospital treatment is rapid transport. So hemopneumo is the presence of air and blood in the pleural space versus just a hemothorax, which is just strictly blood. Again, rapid transport to the hospital. These patients need to get to a surgical area. ER physicians do not place chest tubes. They call surgeons in to do that. At least around here they do. A cardiac tamponade is the protective membrane of the pericardium. So they call it pericardial tamponade or cardiac tamponade around the heart, fills with blood or fluid. The heart cannot pump an inadequate amount of blood because it's being compressed by that fluid in the pericardium. As you can see here, normal heart tamponade. So you can see the fluid build up around this. This is where a pericardial centesis has to be done with a big long needle, 18 gauge needle, goes into the chest wall, into the heart, into the pericardium, and they pull this fluid out, allowing for the heart to pump effectively. With the pressure being exerted from the tamponade that's here is why we're getting narrowing pulse pressures, because the heart can't pump and contract effectively, causing very close diastolic systolic blood pressures. So we talked about Beck's triad, altered mental status, support. We're going to support ventilations and transport rapidly. What is Beck's triad again? Anybody want to take a stab at it? Somebody?
I'm assuming it has something to do with something involved with 3 different areas
Yes.
in the heart.
Okay, so it's 3 things we're going to look for. What 3 things do you think we're going to look for? If the heart can't pump effectively, what's going to back up? Blood, right?
The blood flow and dysrhythmia.
Okay. So if the blood is backing up, what might you see in the neck that might be distended?
Your jugular veins.
Good, there's one. Then the second one would be, if your heart can't pump effectively, you're surrounded by fluid.
Cyanotic.
You're going to have muffled heart sounds, because that fluid around the pericardium, that excess fluid that's there, is going to cause your heart sounds to become muffled. All right, it'll sound very dull and muffled. And then the third thing we're looking for is narrowing pulse pressure. So Charlie said low pressure. So very similar to that, yes. So you're going to have a blood pressures that are very close in number, systolic, diastolic. So like 90 over 86, 90 over 88, because the heart's not pumping effectively, not getting your heart time to rest, because it's always going to be under pressure. So everything will be very close, narrowing pulse pressures. Rib fractures are common, particularly in older people with falls. So a fracture of one of the upper 4 ribs is a sign of a very substantial mechanism of injury. Remember, that's more your stronger ribs up top. A fracture may also cause a pneumothorax, hemothorax, or hemopneumo. Again, so treat rib fractures with care. Don't move the patients around too much, and consider pain management for these. So if you need to call for ALS for pain management, then do so. The signs and symptoms will be localized tenderness and pain when breathing. They'll have shallow respirations, rapid, because they can't take deep breaths because they'll hurt too much. And the patient usually hold the affected portion of the rib cage that's hurting. So what we need to do for pre-hospital treatment really is oxygen to get into the hospital. Even at paramedic level, other than giving pain management, there's not much more we're going to do for rib fractures other than treat them with care.
Are we able to like wrap their rib cage to help with stabilization?
We're not doing too much of that anymore. What I've seen people do before, though, in the back of the ambulance is place like a pillow there so they can hold a little bit of pressure. But we don't do as much wrapping anymore. So back in the 90s, when I first started EMS in the late 90s, we used to carry sandbags on the ambulance. And those sandbags were to put on people's ribs. After a while, they realized that wasn't such a good idea. So as you can see, a flail chest. This is caused by a compound rib fracture that detached a segment from the chest wall. So you can see right here, here's your flail segment. You have two or more ribs broken in conjunction with each other here. And when you're taking a deep breath in and out, as you can see, they're separated too from the costochondral separation right there. So what's happening is that when you take a deep breath in, those ribs stay in one spot, and you'll feel a massive indentation on one side. This is your flail chest. So treatment for this obviously is provide respiratory support if needed, give O2, maintain the airway, and perform an ongoing assessment for complications, looking for attention pneumothorax. Treatment may also include positive pressure ventilation with a BVM if needed. Restricting wall movement is no longer recommended. So again, like we used to carry sandbags for this, but they don't want us restricting the chest wall movement anymore. Another thing we look at too as well is flail chest may also indicate serious internal damage or spinal injury. So there's enough pressure, enough impact to be able to break 3 ribs in a row. You have to take potential for spinal injury as well. Remember, those ribs that are connected go to the spinal column. So if there's enough damage to that, it could have disrupted part of your spinal cord. Rephrase that, part of your spinal vertebrae. Some other chest injuries we're going to come in contact with are pulmonary contusions, which should always be suspected in a patient with flail chest. Pulmonary alveoli become filled with blood, leading to hypoxia. Right? Remember that our alveoli are where the gas exchange happens from the lungs, where oxygen comes in and carbon dioxide comes out. So we need to provide supplemental oxygen and positive pressure ventilation as needed. Sternal fractures create an increase in index suspicion for organ injury as well. And clavicle fractures, which are very, very common, can cause possible damage to the neurovascular bundle. Also suspect upper rib fractures and medial clavicle fractures and be alert for pneumothorax development as well. So you got to pay attention for those as you look for clavicle fractures. Remember, the clavicles are one of the most commonly broken bones, but it's always under pressure as well. This is traumatic asphyxia, as you can see, characterized by distended neck veins, cyanosis in the face and neck, and hemorrhage in the sclera of the eye, which you really can't see here, but you can see the bruising and the discoloration throughout the chest. This is going to be your traumatic asphyxia. Also, it's a sudden severe compression of the chest, which suggests an underlying injury to the heart and possibly pulmonary contusion. All we're going to do in the field for this is ventilatory support, supplemental O2, monitor vital signs during immediate transport. A blunt myocardial injury is bruising of the heart muscle itself. So the heart may be unable to maintain adequate blood pressures for this. So look for chest pain or discomfort and an irregular pulse rate. In the field, though, get a 12-lead EKG on these patients for New Hampshire, Maine providers. Once the new protocol comes out in New Hampshire, you can currently do that as well. Remember, they have chest pain, so get an EKG to see what else is going on. Suspect in all cases of severe blunt injury to the chest. So as far as pre-hospital treatment goes, carefully monitor the patient. Again, 12 leads, very important. Note any changes in blood pressure, run vitals every 5, provide supplemental O2 and transport immediately. So there's nothing that in the field, even at the paramedic level, that's going to be done. Other than get a medic on board to get IV therapy and fluid draining. Commotio Cordis is an injury caused by a sudden direct blow to the chest during a critical portion of the heartbeat. It will result in immediate cardiac arrest, and VFib responds positively to defibrillation within the first 2 minutes of injury. So Commotio Cordis can have, let's say you're on a baseball field and they hit the ball and you take it to the chest. If the ball hits your chest on the QRS complex of the EKG rhythm, what they're saying is it's the RNT phenomenon, where your Q wave, your R wave comes up and coming down for your S wave in that top portion, and it's coming down until you get struck in the chest. It can put you into VFib. So a lot of times you'll see this happen, especially with younger kids that are playing baseball. They take a baseball to the chest and they drop in there in cardiac arrest. Usually it's a Commotio Cordis type deal. So the patients need to be defibrillated. Laceration of the great vessels may result in rapid fatal hemorrhage. We talked about like an aortic dissection. Pre-hospital treatment is called so CPR, ventilatory support, immediate transport, be alert for shock, to monitor changes in baseline or vitals. Any kind of laceration, any kind of great vessel, so you can bleed out quickly. All right, so let's do some review questions really quick, and then I'll call it a day. So when the chest impacts the steering wheel during a motor vehicle crash with rapid deceleration, the resulting injury that kills almost 1/3 of the patients, usually within seconds, is what? A, B, C, or D? So remember that the aorta, aortic shearing, potentially could be the answer here. Remember, it's the size of a quarter, and that's your major blood supply. It's kind of like your supply line, your 6-inch supply line. If you lose that, eventually you'll die or you'll run out of water. It's the same thing. Eventually you'll die, you run out of blood. So, let's do. It's the aortic shearing. Sorry about that. Wrong button. Signs and symptoms of a chest injury include all the following except a couple questions, A's and B's. Any other thoughts? The answer is B. So signs and symptoms of a chest wall injury include bruising to the chest wall instability, increased with pain, breathing asymmetrical, unequal chest movement, if hemothorax is present, and hemoptysis, coughing up blood, if intrapulmonary bleeding is occurring. Hematemesis is vomiting blood, indicates bleeding in the gastrointestinal tract. So again, one is coming from GI, the other one's coming from the lungs. So hemoptysis is what we're looking for if they're coughing up the blood versus just vomiting blood. So those two, understand terminology, because this is what's going to get you guys in the national registry exams. They both have blood coming from the airway. One's coughing, one's vomiting. During your assessment of a patient who was stabbed, you see an open chest wound to left anterior chest. Your most immediate action should be to what? All right, perfect. Cover the room with occlusive dressing. When caring for a patient with signs of pneumothorax, your most immediate concern should be what? See a couple A's, B's, and C's. The answer is C. Pneumothorax occurs when air enters the pleural space and progressively collapses the lung. What purpose does a one-way flutter valve serve when used on a patient with an open pneumothorax? This one I know that I covered a couple times during the lecture.
A.
All right. Let's see what we got. The answer B. So remember, it treats of pneumothorax or a sucking chest wound and serves as two purposes. One, it allows air trapped in the pleural space to escape during exhalation and prevents air from coming back in. Signs of a cardiac tamponade include all the following except what? No worries, Kelsey. I understood what you meant. So, cardiac tamponade, except. All right. So the answer should be C. Remember, in cardiac tamponade, you're going to have distended jugular veins, not collapsed. A patient experienced a severe compression to the chest when trapped between a vehicle and a brick wall. You suspect traumatic asphyxia due to the hemorrhage into the sclera of his eyes. And which other signs would you also pick up on? I'm seeing some A's and B's. B's. I think he meant C, he says. The answer is going to be B. So let's go back one. Remember that if we have traumatic asphyxia, we're going to become very cyanotic. A 14-year-old baseball player is hit in the chest with a line drive, is cardiac arrest. Which of the following is most likely the explanation of what happened? All right, the answer is C, Commotio Cordis. That was the unexplained phenomenon we talked about.
Oh, you are still
Yeah.
there. I thought you left.
For lunch.
Oh.
I'm doing the lecture now with everybody else. This guy. Paradoxical chest movement is typically seen in patients with. Let's see. So number 9. All right, the answer is A. So a flail chest, paradoxical movement. All right, and the last one, number 10. So a 40-year-old man who was the unrestrained driver of a car that hit a tree at a high rate of speed, struck the steering wheel of his chest. He has a large bruise over the sternum and a regular pulse rate of breath and respiratory rate. My goodness, regular pulse rate of 120 beats per minute. You should be most concerned that he is. We have B or C, B's. So the answer is A, myocardial contusion of the bruising of the heart. All right, so I'm going to stop the recording really quick. Let's have a quick discussion with the 7 people that are online right now.